Hi guys, good evening. This is Dr. Sushma, your anatomy educator. Uh, Today, as a part of a neuroanatomy crash course series, we'll be doing medulla oblongata and hopefully meninges. And today is the last day of brainstem. And towards the end of this class, you should have a clear idea about what brainstem is. We also have plans of doing cadaveric image. We'll just do one session just for cadaveric image. But in today's class, you should get a complete idea about what brainstem is. Okay, you should know which cranial nerves come out from which part of the brain. Okay, we'll revise everything once towards the end of the class. I'll also revise brainstem syndromes so that you get a complete picture about what brainstem is anatomically and also brainstem syndromes. Okay, yeah. Now, here at Auricle, we offer you live classes where an educator comes online and they teach you concepts and they clear your doubts. And if you have any doubts at all, you can always log in and ask the educator whenever they come online. And we also have recorded sessions. These recorded sessions will be very useful for you after listening to the live lectures. If you haven't understood anything, you can always go back and read it in the recorded sessions. The videos are of really good quality, and we also offer notes which has lots of diagrams and concepts, which is completely based on the recent CBMA curriculum, and MCQs for your upcoming next examination. Next is going to be a very integrative kind of examination that we are going to see. And these MCQs, when started from right from your first year, is definitely going to help you to ace any entrance exam. And all of this is based on the recent CBME curriculum. Okay, we also have personalized counseling sessions for students who find it overwhelming. You're not able to focus, you're not able to study, and you will be given a mentor who will help you with many things, academic and otherwise. You can always reach out to them, and they'll make a study plan for you which is tailored for you only, and you can plan it, and your examinations will be a cakewalk. And there are three different subscription plans we have. In the basic plan, you have pre-recorded sessions, live class, and just quick examination revision modules. And in the standard plan, you also get access to live sessions, live doubt clarification sessions. And in the premium plan, you will have pre-recorded class, live doubt clarification, one-on-one personalized guidance, notes, and quick revision modules. And you can use my promo code Dr. Sushma 20 for any additional discount on any of these subscriptions. And I can assure you that these plans will definitely help you ace through your examination. Okay. This is the tentative schedule that we have. From 17th onwards, we'll be starting with cerebellum, basal ganglion, going into the motor aspects of it. And in today's class, we will be starting with anatomy of medulla oblongata. Okay. Until now, what have we learned? In the last two previous classes, I taught you in the brainstem, we have midbrain, pons, medulla. Correct? In the midbrain, we have 3, 4, 5 nerves coming out. Pons, we have 5, 6, 7, 8. In the medulla, the remaining cranial nerves obviously will have to come out. Is it not? To appreciate pons and to appreciate medulla, what I was supposed to do, I had to cut the cerebellar peduncles, remove the cerebellum, then only I was able to see. Right? Remembering all of these concepts we had already covered in previous sessions. In today's session, we are going to be starting with the anatomy of the medulla oblongata, and the approach is going to be the same. We're going to be approaching this and studying the anatomy of ventral structure and the dorsal structures of the medulla oblongata. Then we'll take a transverse sections across different levels to see what exactly do we see in medulla oblongata. The approach is going to be the same. The concept is also the same over here, right? What cranial nerves emerge from medulla oblongata? The last four, 9, 10, 11, and 12. Understood? Any doubt? So far, so good? Then let's begin today's class. Okay. Let's look at a clinical case scenario. We have Mr. Johnson, who is about 56-year-old, presents to the emergency department with sudden onset dizziness. Okay. The patient also has difficulty in swallowing and hoarseness of voice. Now I have a very big clue. He reports a sudden loss of sensation on the left side of the face and right side of his body. Upon further examination, we observe that there is nystagmus, ipsilateral Horner syndrome, and dysphagia also. What is the most likely vascular territory involved? Now, guys, look at the different symptoms that he has. He has difficulty in swallowing and hoarseness of voice. There is dysphagia. There is nystagmus and ipsilateral Horner syndrome. Ipsilateral Horner syndrome, meaning there is some sympathetic chain that is getting involved. And looking at the other symptoms, I can say there is involvement of 9, 10, and 11, 12th nerves. Right? Sorry, 12th nerve is not involved over here. I can definitely say there is 9, 10, 11 nerve involvement is there, and there is paralysis of the right side of his body, meaning pyramidal tract is also involved. By the given history, I can definitely place the lesion in the medulla oblongata. Why? Because of the involvement of 9, 10, and 11 nerves, isn't it? Spinal accessory nerve, spinal accessory nerve is not getting involved because there is no drooping of shoulder or anything which is present here. But I can see there is a difficulty in swallowing and hoarseness and everything. So that definitely I can place the lesion is somewhere in the level of medulla. The question is, what is the likely vascular territory? Even without understanding anything about vascular distribution of arteries in the brain, you can still answer this question just by applying logic. How are we going to do that? See, anterior cerebral artery, this does not look like anterior cerebral artery stroke. Moreover, where is the distribution of anterior cerebral artery? It is more anterior, somewhere here, right? I am talking about midbrain and pons and medulla oblongata, which is in the posterior areas of the brain, where the medulla oblongata continues further down as the spinal cord. I can clearly rule out cerebral artery. I can also rule out MCA, middle cerebral artery, because again, middle cerebral artery distribution is also not there in the medulla oblongata region. Now I am confused between posterior cerebral, posterior inferior cerebellar, and anterior inferior cerebellar artery. Between these three, one of the answer is correct. Towards the end of this class, you will tell me which answer is correct out of these three. Out of 5 options, I was clearly able to rule out these 2 options because I localized the lesion in the medulla oblongata. Okay, understood? Yes. Then, how is the gross appearance of the medulla oblongata? Now, medulla oblongata connects pons superiorly with the spinal cord inferiorly. Correct? How does the brainstem look like? We have the midbrain, pons, and medulla oblongata. Medulla oblongata further continues down as the spine. So, medulla oblongata connects the pons superiorly and spinal cord inferiorly. Then, medulla oblongata is conical in shape. This is a very important concept, guys, because I'll tell you why the shape of medulla becomes important as we go further. It has a very broad upper extremity, whereas lower it is kind of pointing and it continues further down as spinal cord. Okay. Now, guys, within the spinal cord, what do we have? Within the spinal cord, we have the central canal. What is there inside the central canal? CSF. I am saying medulla oblongata continues down as spinal cord, but medulla oblongata is not a hollow structure. Medulla oblongata is a solid structure. If it is continuing down further as spinal cord, and inside the spinal cord, I have the central canal which has the CSF. Now, where is this CSF going to go? Are you getting the point? See, I have the medulla oblongata which is continuing downwards as the spinal cord. But medulla oblongata is not a hollow structure. It is a solid structure. Out of nowhere, I cannot have my spinal cord which will have central canal and the CSF trickling down. Because CSF, where is it getting produced? It is getting produced in the lateral and the third ventricles, which further comes down, isn't it? So, something must be there as a connection between the ventricles and the spinal cord that passes via the medulla oblongata, and that is the cavity of the fourth ventricle, which is the open part. The medulla oblongata is a conical structure because the upper extremity which is there, the expands as the cavity of the fourth ventricle, which is the open part. This is a very favorite question in first year examination. There is an open part of medulla oblongata and there's a closed part of medulla oblongata. Correct. The closed part is the lower half of the medulla and the open part is the upper part. Apply the logic. In the spinal cord, I had central canal which had CSF. That means I need to have something in the medulla oblongata also, an open structure which should accommodate the CSF that is being produced. Out of nowhere, God will not create a canal like central canal in the spinal cord, is it not? So, this conical structure, the shape of medulla itself has a reason to it. There is a reason why God made medulla into a conical structure. Okay, the central canal in the up continues upwards as the lower half of the medulla, which is the closed part. In the upper half, it expands as a cavity. So the medulla oblongata has two parts, the closed part and the open part. Closed part is the lower half and the open part is the upper half of the medulla. Okay. Now, what is the blood supply of medulla? Medulla is mainly supplied by anterior spinal artery and medullary branches of the vertebral artery. Anything to memorize here? Medulla continues down further as spinal cord. Obviously, it is going to have the blood supply which is related to spine as well. Anterior spinal, vertebral artery. But we also have another artery which supplies the medulla, and that is pica. That is pica. So I hope you've already got the answer for the previous question that was there in the clinical scenario. Just excuse me, guys. Let me pick up my tea. Thank you. Now, the approach is going to be the same for medulla also, as I said earlier. What am I going to do? I'm going to study how the medulla looks from the anterior surface and from the posterior surface. Same. Now, what are we going to do? Same routine. I have cut open the cadaveric cranial cavity. I have taken out the brain, holding the brain in my hand like this. And I have cut the cerebellar peduncles. Inferior, middle, and superior cerebellar peduncles has been cut. I have taken out the cerebellum and I have kept it outside. Now I am looking at the medulla and I am going to describe the medulla as I am seeing. Okay, are you getting an orientation? I have taken the brain out, cut out the cerebellar peduncles, kept the cerebellum out. Now I have just isolated medulla and I am seeing how it looks. The shape is conical that we have learned. In the anterior surface, what are the different structures that we see? First, we have anterior median fissure, which continues inferiorly with the anterior median fissure of the spinal cord. That's it. But the more important structure is the pyramid, which is a swelling on each side of the median fissure. The pyramids are composed of bundles of nerve fibers called as corticospinal fibers. Are you getting the point? We have a tract, descending motor tract called as pyramidal tract, and this tract passes through the medulla, and the fibers of this tract, they form a swelling, an elevation called as the pyramid in the medulla. This tract was started in the cerebral cortex. It entered the midbrain also. In midbrain also we had this. In the pons also we had this. And in the medulla also we have this in the form of pyramid, right? Yes. And what are pyramids? They are composed of fibers from the corticospinal tract. Look at this, guys. So this is the anterior median fissure, and besides the anterior median fissure, what we have is the pyramids. What we have is the pyramids which contain the corticospinal fibers. Okay? Yes. In the lower part of the medulla, majority of the fibers, they cross over into the opposite side, forming the decussation of the pyramids. Where is the level of decussation? You keep memorizing this in your physiology classes, that the level of decussation of pyramids is lower part of medulla, lower part of medulla. So this is exactly what I'm trying to teach you. In the lower part of the medulla, the pyramids which came from the cerebral cortex, They form a swelling called as pyramid, and they cross over to the opposite side and they decussate. Not every fiber. There is certain bundle of fibers that further, go down in the same side, but majority of the fibers, they cross over to the opposite side. In the pons, if you remember, I told you the transverse pontine fibers in the anterior, pontine region, they actually separate these bundles, isn't it? The same bundles further they descend down and they reach the lower end of the medulla, cross over to the opposite side. Where is it happening? Lower part of the medulla. What is the swelling of these, the collection of these fibers in the medulla called as pyramid? Understanding? Yes. Next, the anterior external arcuate fibers are a few nerve fibers that emerge from the anterior median fissure above the decussation, and they pass laterally over the surface of the medulla oblongata, enter into the cerebellum. Guys, I told you about the pons being the bridge that actually bridges the fibers between cerebrum and the cerebellum. What was the tract called as cortico-pontocerebellar tract? Now, these anterior external arcuate fibers are also the part of this pontocerebellar tract that emerge from the anterior median fissure just above the level of decussation. They pass over laterally over the surface of medulla oblongata and enter the cerebellum. These external arcuate fibers that I'm talking about are a part of this pontocerebellar tract, cortico-pontocerebellar tract. They emerge from the anterior median fissure. Somewhere, this is the anterior median fissure. Before these passes, fibers cross over to the opposite side. The pyramidal fibers cross over to the opposite side. They this anterior external arcuate fibers, they enter into the cerebellum. Okay, they enter into the cerebellum, which are a part of the pontocerebellar tract. Two things we have learned. Number one, pyramidal tract decussation takes place in the lower part of the medulla. Before this decussation, the external arcuate fibers cross over to the opposite side and they go and they enter the cerebellum via the inferior cerebellar peduncle. Okay? Yes. Next, we had the anterior, we had this median sulcus, then we have had the pyramids. Then lateral to the pyramids, we have structures called as the olives, which are formed by this inferior olivary nucleus. Look at the diagram. This is the anterior median fissure. Then we have the pyramid. Then we have the olives. Anterior median fissure, pyramids, olives. So this is the order in which you have to remember. Now, what are these olives? Olives are also these oval elevations which are produced by the underlying inferior olivary nucleus. This inferior olivary nucleus is like a hub of all motor communication, guys. Look at it. You have so many structures which are sorry, we have so many structures which are related to motor aspect. You have this cerebellar tracts which are coming in, you have the pyramidal tract which are coming in. So obviously you need to have a hub over there, which is the inferior olivary nucleus, which kind of interacts with so many tracts and it finally produces some output. Okay, then between the groove between the pyramid and olive is the anterolateral fissure, and we have the rootlets of the hypoglossal nerve coming into picture. Okay, now posterior to the olives, we have the inferior cerebellar peduncles which connect the medulla to the cerebellum. Now, you have to remember one order which is called as PHO, P-H-O. Pho is that panda in the Kung Fu Panda, if you remember. So Pho is that panda, which becomes the dragon warrior and all of that. So remember Pho here. Pho, P-H-O is the spelling. What I'm trying to say is, first you have the pyramid, then you have the rooflets of this hypoglossal nerve. Then you have this olives. So this is the order. First you have the anterior median fissure. Then we have the pyramid. Then we have the hypoglossal nerve. Then we have the olive. This order is very important, guys, because this can be asked in a cadaveric dissection for you. Between pyramid and olive, which nerve is coming out? Hypoglossal nerve. How do we remember it? Pho. P for pyramid, H for hypoglossal, O for olive. Okay, anterior median fissure, first structure that I have is the pyramid, then I have the hypoglossal, then I have the olive. So remember, Dragon Warrior 4 here, P for pyramid, H for hypoglossal, and O for olive. Okay. Then between the the olives and the inferior cerebellar peduncle, I have the all the other nerves coming in. That is glossopharyngeal, vagus, and the spinal accessory nerve. There are 4 nerves that come out of the medulla, right? 9, 10, 11, 12. Hypoglossal comes between the pyramid and the olives. The rest others, as you can clearly see from the diagram, that they come from between the olives and the inferior cerebellar peduncle. Look at this, is the accessory nerve. You can see cranial roots and the spinal root, both roots. This is the vagus nerve, and this is the 8th nerve, vestibulocochlear nerve, which is a part of my medulla. But look at these structures. These are my hypoglossal nerve, which is coming out between the pyramid and olive. This is the glossopharyngeal nerve, this is the vagus nerve, and this is the accessory nerve. All 4 nerves are coming from the medulla oblongata. Okay, this is the anterior aspect of the MO, medulla oblongata. What are the structures that we are seeing? We have pyramids, we have olives, and we have these 4 nerves and anterior median fissure. Okay, yes. Then look at this beautiful diagram, guys. This is a very important diagram, not just for your entrance exam point of view, but also for your cadaveric images. Correct? Any of these nerves can be tied and asked for you to identify. So what different structures can we see? Number 1, we can see the cerebral peduncles. Cerebral peduncles, what are these cerebral peduncles? These are the crus cerebri that contains the descending tracts. Further, come down. Now, what are we seeing here? This is the body of the pons. From the body of the pons, what are we seeing? I cannot see the midbrain here, but I can see the cerebral peduncles of the midbrain. But here, what are the different things I can see? I can see these transverse pontine fibers. This is an anterior section. Able to identify. This is an anterior section. Then, what else I'm seeing? I'm seeing the motor root of the trigeminal nerve. I'm also seeing the sensory root of the trigeminal nerve, which is coming from the body of the nerve. Then, what is the order with which I described in the last class? Which different nerves come from the pontomedullary junction? 6, 7, 8. The medial one is the abducens nerve. Then laterally we have the facial. Further lateral we have the vestibulocochlear nerve. 5th nerve, trigeminal, sensory, and motor roots come from the body of the pons. 6, 7, 8 come from the pontomedullary junctions. Then come to the medulla oblongata. Here you can see between pyramid and olive, I have the hypoglossal nerve. Mnemonic is 4, pyramid, hypoglossal, then olive. All 3 other nerves, they emerge between the inferior cerebellar peduncle and the olive. You can clearly see how the cerebellum is cut off here. Clearly see how the cerebellum is cut off. You can see the middle cerebellar peduncles here, right? So this is the section that you cannot afford to go wrong, because you should know where these cranial nerves are coming out. Okay? Yes, I hope you are able to orient yourself into this. Next, let's go to the posterior surface, guys. The posterior surface of the superior half of the medulla oblongata is open, correct? And the lower part, it forms the lower part of the floor of the 4th ventricle, isn't it? The posterior surface of the inferior half of the medulla, which is the closed part of medulla, is continuous with the posterior aspect of the spinal cord. The upper part forms the floor of the 4th ventricle. Lower part continues with the spinal cord. With what I'm talking about, posterior surface. Anterior surface, what are the 2 different things I taught you? Pyramid, olive, and different nerves emerging from between pyramid and olive, and between olives and the inferior cerebellar peduncles. Now come to the posterior surface. In the posterior surface, the upper part forms the floor of the 4th ventricle. Lower part continues further down with the spinal cord. Okay? Yes. Now, let's talk about the lower part of the posterior surface of the medulla, and upper part is a different discussion altogether, where it forms the floor of the 4th ventricle. Now, the lower part possesses a posterior median sulcus. On each side of the sulcus, we have gracile tubercle produced by the gracile nucleus. Lateral to the gracile tubercle, I have cuneate tubercle produced by the underlying cuneate nucleus. Anything that is ringing in your head when I say gracile and cuneatus? Anything that comes to your mind at all? What is coming to your mind when I say the word gracile tubercle or when I say nucleus gracilis? Yes, you're absolutely right. These nuclei and these swellings, elongated swellings, are a part of dorsal column pathway, dorsal column pathway, dorsal column tract. What sensations are carried by dorsal column tract? Vibration, proprioception, crude touch. You should know in and out about these tracts and pathways because it's going to help you immensely to crack any question in physiology, anatomy, as well as in your entrance examination. In the lower part of the posterior surface of medulla, what do we have is gracile nucleus and cuneatus nucleus. Let me just give you a brief overview about this tract. Dorsal column pathway is the middle one, right? Dorsal column pathway is the medial pathway which carries the proprioception, vibration, and the crude touch. The first order neurons, they come from the receptors, they go into the spinal cord on the same side, they ascend upwards, they reach this gracile and the cuneatus nucleus. From the gracile and the cuneatus nucleus, the second order neurons arise, which are the internal arcuate fibers. These second order neurons cross over to the opposite side in the medulla and then they reach the thalamus. Second order neurons arise from this nucleus gracilis and nucleus cuneatus. These second order neurons cross over to the opposite side in the medulla. Then they reach the thalamus. From the thalamus, you have the third order neurons which reach into the cortex. So this nucleus gracilis and nucleus cuneatus, which carry the sensation of proprioception and vibration, give rise to the second order neurons of the dorsal column pathway, where they are present on each side of the median sulcus. So whenever there is any damage to the middle aspect of the medulla, medial aspect of the medulla, then what sensations will be lost? Dorsal column pathway sensations. Vibration is gone. Proprioception is gone. Crude touch is gone. Right? So on the lower part of the posterior surface of the medulla, I have this nucleus gracilis and nucleus cuneatus. Because they are present, there is a swelling called as gracile tubercle and the cuneate tubercle. Understood? What is present in the lower part of the posterior surface? Very, very, very important concepts, guys. Okay. Then let's go to the upper part of the posterior surface, which forms the floor of the fourth ventricle. See, fourth ventricle is quite a bigger, again, the fourth ventricle is further divided into upper and the lower part. I'm talking about the lower part of the floor of the fourth ventricle. I'll teach you ventricles when we go in subsequently in our classes. But today, just know this much key. In the lower part of the fourth ventricle, I have the upper part of the posterior surface of medulla. And I know I'm using all of these upper part, lower part, posterior, anterior. I hope you're getting an orientation. Here I'm talking about the posterior surface of the medulla, in which I'm talking about the upper part. The lower part, I had this cuneatus and the gracilis. Upper part, what are the different structures that I see? In the upper part, you have three important triangles: hypoglossal triangle, vagal triangle, vestibular area. Okay? Hypoglossal, vagal, and vestibular. Now, on the either side of the median sulcus, there is an elevated inverted V-shaped area called as hypoglossal triangle. Lateral to the hypoglossal trigone is the vagal triangle. Then, the sulcus limitans lies lateral to the vagal triangle and separated from the vestibular area which overlies the vestibular nucleus. Now, look at this, guys. This is the central median sulcus. Here is the hypoglossal triangle and here is the vagal triangle, and the sulcus limitans separates it from the vestibular area. Let me show you one more clear picture. Yes, look at this, guys. So this is the floor of the fourth ventricle. This is the posterior aspect of medulla and this is the anterior aspect of medulla. Correct? Now this is the posterior aspect of medulla and I can see the inferior cerebellar peduncles are cut and I have taken out the cerebellum. Now I am looking at this. Yes. In the lower part, I told you, I have the cuneatus and gracilis. Understood? And the median sulcus is here. This is the cuneatus and this is gracilis. Now look at the upper part. Look at the upper part. Now, first, immediate medial structure to this median sulcus is the hypoglossal triangle. Then what separates my hypoglossal triangle from the vestibular area is the striae medullaris. Sorry, not I have written it wrong over there. It's not sulcus limitans. Sulcus limitans comes in the pontine area. It is actually the striae medullaris that separates the hypoglossal area from the vestibular area. I'm really sorry. Apologies for that. Then I have the vagal triangle beneath the hypoglossal triangle. Then this is the entrance into the central canal. Whatever the CSF that was produced in the fourth ventricle trickles down into the central canal through this area. That is the reason why we have an open structure over here. The upper part is open and lower part is continuous with the spinal cord, which is the closed part of medulla, and this is the open part of the medulla. Posteriorly, in the lower part, you see cuneate tubercle, gracile tubercle, and in the upper part, we see the median sulcus, and then we have the hypoglossal triangle and the vagal triangle, and striae medullaris separates the hypoglossal triangle from the vestibular area. Sulcus limitans is present in the pontine area. Sulcus limitans is the one that separates the alar plate from the basal plate in the developing neural tube, isn't it? Yes. Let's go back. In the upper part, yeah, this is the striae medullaris. You can see separates it from the, from the vestibular area, and this is the vagal triangle. This is the hypoglossal triangle, and this structure is the gracilis, and this is the cuneatus. You can clearly see how the cerebellum is exposed. You have taken out the cerebellum like this. Then only I can see and visualize the structures in the medulla. Understanding? Anteriorly, what did we see? We had pyramids and olives. Posteriorly, in the upper part, we have the hypoglossal triangle and vagal triangle, striae medullaris. In the lower part, I have nucleus gracilis and nucleus cuneatus, cuneate tubercle and the gracile tubercle. Correct? Anteriorly, we had pyramid olive and all the nerves coming in. That is it, guys. That is the structure of medulla oblongata, and that is all you are expected to know in your examination. In your examination, they will ask you to name the structures in the anterior as well as in the posterior surface. You will have to cut open the cerebellar peduncles to be able to visualize this. Okay, and you can clearly see the trochlear nerve which is coming out. Yes. Now, again, just another picture. You can see the trochlear nerve which has come out in a posteriorly like this. Then we have the the median sulcus. Then we have the medial eminence. Here you have the sulcus limitans, right? Here you have the sulcus limitans, and this is the vestibular area. This is the facial colliculus. I hope you remember facial colliculus. Then we have the inferior cerebellar peduncles, and this is the striae medullaris that separates this hypoglossal area from the vestibular area. Correct? Then we have the nucleus gracilis, nucleus cuneatus. You can see the tubercles here. This is the posterior aspect. How do I know it is posterior? Number one clue, giveaway clue is the trochlear nerve that is coming out. Okay? Yes. Now, let's look at a simple question. A 32-year-old patient presents with isolated sixth nerve palsy. Which part of the brainstem is likely affected? Sixth nerve comes out from which part of brain, guys? 3, 4, 5 comes out from midbrain. 5, 6, 7, 8 comes out from pons. 9, 10, 11, 12 comes out from medulla. So here you have abducent nerve palsy. So obviously option B is the right answer here. Okay, simple enough to understand. I hope you don't have any doubts with this. Yes, let's move ahead. Now, I've taught you how the medulla looks anteriorly and posteriorly. Now, what I'm going to do is I'm just taking sections. I'm cutting open medulla at different levels. I'm taking these sections out. After I take the section out, I'll see what different structures are seen. That's it. Now, as the spinal cord Medulla oblongata also consists of white matter and gray matter, like any other CNS structure. Next, internal structure is studied under level of decussation of pyramids, level of decussation of lemnisci, level of olives, and just inferior to the pons. Okay. Now, let's study it at the level of decussation of the pyramids. Yes. A transverse section through the inferior half of the MO, medulla oblongata, passes through the decussation of pyramids in which the following structures are seen. Obviously, we are talking about the medulla oblongata. So, what cranial nerve nuclei can you see? Number one, you will see the spinal nucleus of trigeminal nerve. I keep repeating this point a lot of times. Trigeminal nucleus is a very big nucleus which has three different parts. Mesencephalic part, then there is a chi principal, and then there is spinal. Okay, there are three different parts to the spinal trigeminal nerve nuclei. All three different parts of the trigeminal nuclei carry different sensations from the entire body wall. Correct? Mesencephalic is proprioception, and you will tell me in the next class what spinal nucleus carries. Okay, what sensation does spinal nucleus carry? Okay, and what part of trigeminal nucleus lies in the medulla oblongata? That is spinal nucleus. Spinal nucleus and accessory nucleus is present here. Spinal accessory nucleus. Of course, I've already taught you nucleus gracilis and cuneate is present, which is part of the dorsal column. If you know if you know what anatomy is there, or if you've understood what anteriorly, posteriorly structures are present, you can clearly, you can write it without even by heart. Okay, then motor tracts. What different motor tracts do we have? We have decussation of corticospinal tracts and pyramids, right? Anything difficult? All these structures we have already covered. Just write the same thing here. Is there anything difficult, or is there anything that you need to you need to open the book and it's so you keep complaining to the teachers that anatomy is very volatile, I'm not able to understand, I'm not able to orient myself? Just look at the logic here, guys. Whatever that we saw in the anterior and posterior structures are the same repetition over here also, isn't it? Then what different sensory structures are there? Spinal tract of trigeminal nerve. Why? Because we have spinal nucleus. Posterior spinocerebellar tract and lateral spinothalamic tract. Then also we have anterior spinocerebellar tracts. Yes, these are different tracts that are present. You are not expected to identify this diagram. I've just placed it just for the sake of reference. Okay. Yes. Now, decussation at the level of the pyramids again. Now, this decussation of the pyramids is a great motor decussation in the sense, in the superior part of the medulla, the corticospinal fibers occupy and they form the pyramid, right? In the lower part of the medulla, about 3/4 of the fibers, they cross over to the opposite side and continue down the spinal cord in the lateral aspect is the lateral corticospinal tract. Then these fibers in the lower part of the medulla cross over to the opposite side, and they serve as the continuity between the anterior column of gray matter of the spinal cord as well as the gray matter that surrounds the central canal of the spinal cord. Okay. Yes. Now look at it. From the cortex, the fibers are coming in. They are coming in, and they've entered into the lower aspect of the medulla, crossed over to the opposite side, and they've entered into the spinal cord. Okay. So this is the pyramidal tract. Where is the level of decussation? Lower aspect of medulla. Upper aspect of medulla, they form the pyramids. Okay. Next, gracile nucleus. This nucleus lies close to the posterior median sulcus. Correct? Now, I've already explained this. They receive their afferents from the termination of the gracile tract. Now, what is this gracile tract? These are the axons of the dorsal column pathway, first order neurons, which come from the mechanoreceptors and other peripheral receptors. They enter into the spinal cord. They go around, same side, and they reach the nucleus gracilis, isn't it? Then they reach the nucleus gracilis. From the nucleus gracilis, I have the internal arcuate fibers, which cross over to the opposite side, and they reach the thalamus. In the thalamus, they third order neurons, they synapse with the third order neurons. Third order neurons enter into the cerebral cortex. Look at this beautiful structure, beautiful tract. The mechanoreceptors, there could be Pacinian corpuscles or Merkel cells and all of these. From here, they enter into the gracile and the cuneate nucleus in the medulla oblongata. Internal arcuate fibers crossed over to the opposite side, entered the pons, entered the midbrain, entered the thalamus. What neurons are they? Second order neurons. Second order neurons then synapse in the thalamus. From here, the third order neurons arise. They enter into the cerebral cortex. Enter into the cerebral cortex. Anything difficult over here, guys? In the same class, you have revised the entire dorsal column pathway also. What different sensations do they carry? Cuneate carries the proprioceptive fibers from the upper half. Gracilis carries from the lower half. How do we remember? Gracilis, L. L is the lower limb. Okay, gracilis is lower limb. Why? Because gracilis has a L. L for lower limb. Cuneatus carries from the upper part of the body. Okay, cuneatus you can also remember Q. Q means upper limb. CU, right? You can remember as cuneatus because it has U upper limb. Gracilis is L. Just a small mnemonic here. That's it. Then accessory cuneate nucleus. This lies dorsolateral to the cuneate nucleus, and this nucleus receives fibers from the cervical region of the spinal cord, which ascend through the cuneate tract. There is some other, cuneate tract is one tract in which you also have some fibers reaching from the cervical region of the spinal cord. Now, axons of the cells of this nucleus, they form the dorsal external arcuate fibers. We had anterior external arcuate fibers also, remember? In the very beginning, I spoke about this. And we also had internal arcuate fibers. How many arcuate fibers are we coming across? 3 already, right? Then they reach the cerebellum through the inferior cerebellar peduncle. These fibers carry the proprioceptive impulses from the neck and the upper limb to the cerebellum on the same side. Okay. Now, level of the sensory decussation. At the level of sensory decussation is where the meniscus arise. Correct. Now, transverse section through the inferior half of the medulla, a short distance above the decussation of the pyramids, is where the decussation of the lemnisci takes place. Now, what are the different nuclei that we see? Again, there will not be any much of difference, guys, because we are just talking about few millimeters and centimeters. Okay, same cranial nerve nucleus are also present. Same nucleus gracilis, same nucleus cuneatus, same pyramidal tract. Only difference is in the sensory tract, you have the decussation of the medial lemniscus. Medial lemniscus is a part of dorsal column pathway. Remember, and also you have the fasciculus gracilis and fasciculus cuneatus. Right? Rest everything else is the same. Only difference is that presence of this fasciculus gracilis and cuneatus. Okay. Next, this sensory decussation is formed by the fibers of the internal arcuate. Correct? Internal arcuate fibers that arise from the nucleus gracilis and cuneatus forms the sensory decussation. As simple as that. That you can remember. Okay. Next, after they cross over to the opposite side, then they form medial lemniscus. Guys, medial lemniscus or any lemniscus is always a second order neuron. They are never first order neurons. All of this lemnisci is formed only after the fibers are crossed over to the opposite side. You take any lemniscus, spinal lemniscus, medial lemniscus, a lateral lemniscus, any lemniscus example you take, all whenever you hear the word lemniscus, they are an example of second order neurons, and all of these are formed only after the fibers have crossed over to the opposite side. Once the internal arcuate fibers cross over to the opposite side, then they form the medial lemniscus, which enter the thalamus. Okay, they are the second order neurons. Next, let's take a simple question. 45-year-old man presents with a spastic hemiparesis with loss of vibration and proprioception of left side. Which ascending pathway is likely affected? Now, guys, question is it a motor pathology or a sensory pathology? I can see both. There is spastic hemiparesis also, and also there is loss of vibration and proprioception. But let's just focus on the vibration and proprioception because question is asking what ascending pathway is likely affected. Now, Corticospinal tract. Is corticospinal tract an ascending pathway? No. Do pyramidal tract contain fibers for vibration and proprioception? No. So then A is not the answer. Then go to the rubrospinal tract. Rubrospinal, from red nucleus to spinal cord. Is it anywhere looking like a sensory tract? Of course not. Vestibulospinal, again, looks like a motor tract? No. Then I have dorsal column and spinothalamic. Now, what sensation are carried by dorsal column? Vibration and proprioception. That's what the question is also asking. What sensation are carried by spinothalamic tract? Anterolateral, fine touch, temperature. All of these are from spinothalamic. So it cannot be spinothalamic because vibration and proprioception is lost in this case. So answer for this question is undoubtedly dorsal column pathway. This is how questions come in your examination. This is how questions are asked even in your entrance examination. It's a simple concept, and this is how you even see your patients in your OPD. Somebody just comes to you into the emergency in your night duty. Patient just comes to you and he says, okay, I cannot feel the pain, I cannot feel temperature. My wife just put a hot coffee cup over here, but I don't feel any sensation. And patients, these are all symptoms of stroke. These are all symptoms of stroke, isn't it? This is how even patients come to you when you're sitting in the OPD. Small little things that you're learning in anatomy class contributes to this entire building that you're going to build over this foundation after first year. That is you becoming a clinician. Okay, grasp these concepts properly and keep studying these concepts over and over again. This is going to help you immensely once you become a clinician. Next, at the level of olives, if you take a transfer section through the olives, again you can see the olives is a little lower down, right? You have the pyramids and the olives. What different structures do we see here? We see the trigeminal nerve, vestibular nucleus, spinal nucleus of the trigeminal nerve, vestibular nucleus, glossopharyngeal, vagus nucleus, nucleus ambiguous also, and tractus solitarius. Okay, and inferior olivary nucleus. Again, it's very difficult, guys. I mean, as I keep saying, it's very difficult to memorize this. Okay, difficult to memorize this. Just apply logic. Just remember the diagrams. That's the only way you can write. See different, section of medulla oblongata at different levels. All right, very easy, guys. At the level of olives, you see all of this nerves and everything, isn't it? To have this minor little understanding, you should have the understanding of how the structure of MVO looks from anterior as well as in the posterior aspects. Then writing different structures and the diagram is just a cake walk. Okay, yes. Then just a second, guys, I'm not able to see. Yeah, next we have the inferior olivary nucleus. Now this is a prominent structure that is responsible for the surface swelling of the olive. Why olives are called as olives? Because of the presence of this inferior olivary nucleus. Again, this is a definition of ION which we keep memorizing in our first year. It's a corrugated bag of gray matter with the Hyler's mouth, which is directed medially. What is a corrugated bag of gray matter? I still remember memorizing this from my first year. Okay. Now, the smaller and the dorsal medial accessory olivary nuclei is also present. The cells of the ION send fibers medially across the midline to enter the cerebellum through the inferior cerebellar peduncle. As I told you, ION is like a hub of many motor things that take place. Now, afferent fibers reach the ION through spinal cord, cerebellum, as well as in the cerebral cortex. Function is mainly associated with basically voluntary muscle movement and many motor things only. Okay. Hypoglossal nucleus, hypoglossal nerve, where is it situated? It is situated at the floor of the fourth ventricle. Correct. It forms the hypoglossal trigone, which is a triangular elevation. Hypoglossal nerve originate in the ipsilateral hypoglossal nucleus and supplies the muscles of the tongue. I hope you know muscles of tongue, like there is genioglossus and so on, which we'll do when we go to the head and neck. Next, dorsal motor root or motor nucleus of the vagus. This is the principal parasympathetic nucleus of the brainstem. Correct. Vagus has a very long nerve supply where it goes, even the fibers even travel into the thoracic area and as well as the abdominal viscera. Correct. Yeah, but where is the motor nucleus present? Motor nucleus is present in the floor of the fourth ventricle. Then solitary nucleus. It lies deeper at a very deeper plane in the open medulla, closer to the medial surface of the inferior cerebellar peduncle. And it extends downwards to the closed medulla and lateral to the dorsal nucleus of the vagus. Not very important for you. Next, a very important small addition that I've done. I know it's not very important for you. I've only done this to make the class a little interesting and to make the concepts a little interesting. I keep repeating the same thing, that from the midbrain I have the third, fourth and fifth cranial nerves. From pons I have 6, 7, 8. Medulla I have 9, 10, 11, 12. Just look at this, guys. What is Weber syndrome? Weber syndrome is ipsilateral third nerve palsy and contralateral hemiplegia. There's Benedict syndrome, where there is ipsilateral third nerve palsy and contralateral chorea and resting tremors. Non-tangential involves ipsilateral third nerve and contralateral ataxia. Third nerve comes from midbrain. Along with third nerve, different structures may get involved. If red nucleus gets involved, results in Benedict syndrome. If pyramidal tracts get involved, results in Weber syndrome. Isn't it? Just one nerve palsy with some other motor manifestation gives rise to a different brainstem syndrome altogether. Look at the Millard-Gubler syndrome. 6-7 palsy, facial paralysis and hemiplegia. Fowell syndrome, 6-7-8 plus INO and hemiplegia. Lateral gaze palsy is seen in Fowell syndrome. Look at medulla. Medial medullary syndrome, which we described in our previous question, ipsilateral 12th nerve plus contralateral hemiplegia. Lateral medullary syndrome, loss of pain temperature from the opposite side, 10th nerve palsy. And in lateral medullary syndrome, you also have involvement of the sympathetic chain resulting in Horner syndrome. Okay, now coming back to our question, coming back to our first clinical case scenario question. If you see this, see the clinical case scenario question. Johnson, a 56-year-old male, presents to the emergency with sudden onset dizziness, difficulty swallowing and hoarseness. He also has ipsilateral Horner syndrome. Clearly, this is a lateral medullary syndrome. Artery is pica. Ideally, it is actually the vertebral artery that is responsible for this. But yes, of course, pica also results in this lateral medullary syndrome called as Wallenberg syndrome. All these syndromes are not very important for you per se for your first year, medical examination, as such prof examination, but you can clearly see if a patient comes to you with so and so pathology. Third nerve palsy is down and out pupil. Somebody comes to you with down and out pupil, there is drooping of eyelids and all of this, pupillary reflex is lost, and he comes to you with hemiplegia, one side of eye is gone, one side of body is gone, then you know where the syndrome is. It is the Weber syndrome. That is how important this topic is, because an entire chapter of strokes depends upon your understanding of brainstem. And I have designed all these classes in such a way to make it easier for you to understand and approach this concept of brainstem syndromes. Either you can study this and go work, work backwards and start writing diagrams that way, or I would suggest just know 3, 4, 5 comes from the midbrain and you can write the related structures. 6, 7, 8 comes from pons, 9, 10, 11, 12 comes from medulla. And then in the medulla, you also have so many things like pyramids, olives, and you have the nucleus, gracilis, and cuneatus, and important decussations and everything. But the whole point of studying brainstem is to understand this one particular slide. If you have understood brainstem well, you will understand this slide easily without having any difficulty. If you've understood brainstem syndromes, half of your neuroanatomy is done, even in your final year as well as in your entrance examination. Okay, that's how important brainstem is. I hope towards the end of these all 3 classes, you're able to understand and get an orientation about what brainstem is and how pons is organized, how different tracts are organized in brainstem. I hope series of these three classes were helpful to you, and we shall definitely cover meninges in the upcoming sessions. Today I'm really running short of time, and we have lots to finish in meninges as well. Okay, and thank you so very much for staying with me. I wish you all the very best. And if you have any doubt, you can reach out to us across all the social media handles. I wish you guys all the very, very best. Keep studying, keep hammering. There is no substitution for hard work, and repetition is the mother of all skills. Keep studying, keep reading. You will definitely reach your goal. Okay? Thank you so very much. I'll see you in next class. Good night, guys.